Today we are going to present specifically our journey of past 30 years and the 500 about this. And we are also going to have our colleagues who have been associated for all this. I welcome all of you once again and hand over now to Dr. Piyush. This is a new team that is taking over the art. Dr. Piyush, please. Thank you, sir.
So welcome to the CGR, and the topic is the little big bone breakers. So this is all about the giant parathyroid adenomas that we encounter, and what exactly these parathyroid adenomas are. This is a pathological condition of the parathyroid gland, usually 4 in numbers at least, and there is proliferation of the tissue and excess parathormone production, which leads to excess calcium production in the body, and which has got a lot of systemic effects, and it affects bone predominantly. That's why the topic, the little big bone breakers. So we are talking about the oversized parathyroid adenomas. This is a rare variant. Anything above 3.5 grams are labeled as GPA, the giant parathyroid adenomas. The normal glands weighs 30 to 50 milligram. So this is the weight of a normal gland. Surprisingly, in our country, we tend to get larger glands, the heavier glands, up to the range of 1.5 grams. And this relates to the results of other studies across the country. But today we'll discuss about this big gland, the giant parathyroid adenomas. Now, are we really interested in the size, or there is something else to it? So, the larger the size is, heavier the gland is, it can be associated with significantly raised parathormone level as well as calcium level, and which can lead to severe hypercalcemia or hypercalcemic crisis. And because of the sheer size, it can mimic malignancy. Now, from where this 3.5 gram number has come from? So studies are there to demonstrate that if we take a cutoff of 3.5 gram, we can establish the relationship between the tumor size and the serum PTH concentration. Below this, the relationship is lost. Then coming to hypercalcemic crisis, anything above 14 milligram per deciliter, this is a serious condition. Earlier, the mortality rate was quite high. Even in the modern age, it is around 10%. So how we treat this? We start with IV normal saline along with calcitonin. And the reduction in the calcium level is attained within 12 to 48 hours, which gives us a window of opportunity to intervene. And later we can start bisphosphonate, which gives us sustained relief. Calcitonin cannot be the treatment with calcitonin cannot be prolonged because of tachyphylaxis, which is down regulation of the receptors. This giant parathyroid also mimics malignancy. As the features, biochemical and clinical, they are of malignancy only. Pre-operative FNAC is not advisable because of the tumor seeding, histological alteration of the tissue, and there is something called parathyroid mitosis, wherein seedings of the parathyroid gland occurs and they act as independent parathyroid edema later on, causing hypercalcemia. Frozen section intraoperatively is less accurate, again not routinely used. So what to do? We tend to rely more on IHCs, particularly Ki67, which is a proliferative marker, parafibromine and galactine. Wherever there is a suspicion, we go for en-bloc resection of the parathyroid gland along with the thyroid and cervical lymph nodes. With this, I would now like to request Dr. Kiran to tell you about the clinical presentation of this pathological condition.
Thank you, sir, for giving me this opportunity to present clinical presentation of primary hyperparathyroidism. So here I would like to present the data from Indian PHPT registry and an unpublished data from the AIIMS study recently which has been done. So here, Indian PHPT registry, which contains centers from Chandigarh, PGI Chandigarh, AIIMS New Delhi, Kolkata, APG India. So here we can see, so there is a raise in the incidence of the primary hyperparathyroidism over a period of years. So coming to the manifestations, so primary hyperparathyroidism can present with bone disease, renal disease, or gastrointestinal disease. The bone disease contains the manifestations of bone pain, bone fracture, and osteofibrosis cystica. So here, so the incidence of bone manifestations like bone pain has been reduced from 56% in 2018 to 29%, which is unpublished data from AIIMS, and 27% of the bone fractures has been reduced to 15% of the bone fractures. So there is a reduction in the severity of the disease over a period of years. Coming to the renal manifestations, so it can be like renal stones or nephrocalcinosis or low GFR. So it is also reduced. There is also reduction in severity in renal manifestations like 71.7, 42% of renal stones to 29%, and 28% of nephrocalcinosis to 6%. Similar trend has been seen in the gastrointestinal disease, pancreatitis, which is 16% in 2018 to 13% in the 2021 data. So similarly, there is an increasing trend in the asymptomatic presentation of primary hyperparathyroidism. So from 5 to 6% in the 2017 to 10% in the 2020. So it has increased to 26% in the AIIMS study. So these increased trend in the asymptomatic presentation can be because of the yearly health checkup, which includes the serum calcium, and there is an increased awareness among the physicians for metabolic bone disorders. So coming to the primary hyperparathyroidism, which is presenting as giant adenomas. So usually giant adenomas can be classified like large parathyroid adenoma, whose mass can be from 1 to 3 grams, and giant parathyroid adenoma whose weight can be from 3 to 3.5 grams. So these adenomas will present symptomatically in 90% of the patients. So 10% of the patients will present asymptomatically. So and the clinical presentation is somewhat different from the small primary hyperparathyroidism patients. So here these patients present with 58% of the patients present with the palpable neck masses, and 42% of the patients present with fatigue, which is less common with the small parathyroid adenomas. So here bone pain and bone fracture and renal colic and abdominal pain has been seen very much less commonly when compared with the primary small parathyroid adenomas. So here the first study where giant parathyroid adenomas has been established, mass has been established, also shows similar trend, like 53% of the patients presented with asymptomatic presentation. So recent systematic review and meta-analysis has revealed that 90% of the patients have symptomatically, and 10% of the patients with asymptomatic features, and they lack classical primary hyperparathyroidism features, and the localization is also different from small parathyroid adenomas. Like, so there will be increased ectopic presentation like mediastinal 30.8% and intraparathyroidal around some 8%. So here disease severity has been low in giant parathyroid adenomas, and but there is incidence of post-operative hypocalcemia and Hungry bone syndrome will be more in the giant parathyroid adenomas. So here the study from India, which included syndromic association of giant adenomas. So where they have studied 2 cases. Around the world, only 10 cases has been presented like giant adenomas and men syndrome. In these cases also, non-classical presentation of PHPT has been seen, like giant mediastinal ectopic adenomas presented with dyspnea, fatigue, and chronic kidney disease. So there are multiple factors which can be associated with the variation in the clinical features between small parathyroid adenomas and the giant parathyroid adenomas. So one can be like vitamin D. So giant parathyroid adenomas has increased the incidence of vitamin D insufficiency, which has been proved in many studies from Rao et al. And Mittal et al. So after vitamin D fortification has been done, so there was a 3-fold reduction in the size of the PTH adenoma. Thank you, sir. Thank you for giving me this presentation. Now I would like to invite Kanika to explain the biochemical presentation.
Thank you, Dr. Kiran. So now moving ahead with the So now coming to the biochemical diagnosis of primary hyperthyroidism, which is mainly a biochemical diagnosis, which is characterized by hypercalcemia and raised parathormone. So the further investigation we would like to get done is, one is the serum calcium. Later we proceed with the intact PTH, 25-hydroxy vitamin D3, 24-hour urinary calcium, serum phosphate, and serum alkaline phosphatase. So the first test is the total calcium. That is, we measure a corrected total calcium and ionized calcium. Using the formula, that is, we subtract the serum albumin of the patient by 4, multiplying it with 0.8 and adding it to the serum calcium of the patient. So it is seen that the sensitivity of ionized calcium and the corrected total calcium when done separately is 96%. But when these tests are used combined together, the sensitivity raises up to 99%. Once we have the hypercalcemia, we go ahead with measuring the intact PTH, which we do by using a 3rd generation immunometric parathormone assay. But in certain cases, the patient do present with normocalcemic hyperparathyroidism. So in those cases, we get this max PTH done, which should be less than the normal PTH. So once it's less, then we know it is a primary case of primary hyperparathyroidism. So the basic for diagnosis, only these two tests are required. The further tests are mainly to distinguish it from the other causes of hyperparathyroidism. That is the 25-hydroxyvitamin D. So it is normal in primary hyperparathyroidism and even in normocalcemic hyperparathyroidism. So only recommended to rule out causes of secondary hyperparathyroidism. And patients where we have a doubt, so in those cases we usually supplement vitamin D and repeat the value, and then we can establish the diagnosis. Next is the 24-hour urinary calcium. So this is not required always, but in certain cases of asymptomatic hyperparathyroidism or normocalcemic hyperparathyroidism, or patients, or when we have to distinguish it from familial hypocalciuric hypercalcemia, we go ahead with this test. If we have a doubtful case, then we further calculate the calcium creatinine clearance ratio using this formula of 24-hour urinary calcium, serum creatinine, and 24-hour urinary creatinine. So it is said that when the ratio is more than 0.02, then we are sure of it being a primary hyperparathyroidism. Whereas when it is less than 0.01, we further get a vitamin D values, and if it's low, still low, then we establish the diagnosis of familial hypocalciuric hypercalciuria. So phosphate levels, if seen, they are usually low. So, and it is seen that 42% of the patients usually have low values, but ranging from a level of 2 to 2.5 milligrams per deciliter. Next is the serum alkaline phosphatase. So this serum alkaline phosphatase is mainly is to assess the bone disease risk, and also to assess the risk of patient developing post-operative hungry bone syndrome. And it's seen if preoperative values are more than 340 units per liter, the risk of developing hypocalcemia post-operatively is even more. So now just to summarize what we read, so whenever a patient comes to us with a hypercalcemia, that is, we are sure that it is a PTH dependent hyperparathyroidism, we get a calcium creatinine clearance ratio. If it's more than 0.02, we are sure of it being a primary hyperparathyroidism. If it's less than 0.01, we are again doubtful of the familial hypocalciuric hypercalcemia. So we go with the vitamin D levels and supplement it and repeat the values. If now the vitamin D levels are normal, then we know it is a familial hypocalciuric hypercalcemia. So this is just a table which depicts various other causes of hyperparathyroidism. But in our case, that is primary hyperparathyroidism, we see that there is raised serum calcium, the parathormone levels are raised or appropriately normal, the phosphate levels are usually low, and with the urinary calcium excretion of more than 1%. So now I would like to call Dr. Shreya to help us with the diagnosis of radiological localization.
Good afternoon, everyone. So I'll be presenting the radiological localization of parathyroid adenomas. The main role of radiology is to localize a parathyroid lesion in the setting of biochemically diagnosed hyperparathyroidism. So we attempt to provide an accurate pre-surgical localization of the lesion so as to facilitate surgery. The imaging modalities which we have available. So the first line imaging modality is high resolution sonography of the neck. Nuclear scans are complementary to ultrasound. 4D CT is indicated in disconcordant cases. MRI has a limited role predominantly in the evaluation of ectopic and recurrent and residual disease. CEOS is a novel technique which is currently being done on an experimental basis in our department. So coming to the ultrasound B mode findings, on ultrasound we can see a well circumscribed hypoechoic lesion which is oval to round in shape, and usually it is located in posterior or inferior to the thyroid gland. When we put color Doppler, we can see a hypertrophied feeding vessel which is arising from a branch of the inferior thyroid artery feeding this parathyroid adenoma, forming a polar vessel sign or a rim or arc of vascularity around it. So the two important differentials of parathyroid adenomas on ultrasound are lymph nodes and thyroid nodules. So in order to differentiate it from lymph nodes, we look at the echogenicity as well as the vascularity. Parathyroid adenomas tend to have a homogeneously hypoechoic echotexture, while lymph nodes tend to have a central echogenic hilum. A peripheral arc or polar vessel sign tends to be seen with parathyroid adenomas, and lymph nodes tend to show a central or a hilar vascularity. The second important differential is a thyroid nodule. So thyroid nodules tend to have a more heterogeneous echotexture as compared to parathyroid adenomas. The peripheral polar vessel sign is seen more commonly with parathyroid adenomas, not seen with thyroid nodules. Areas of cystic change and calcification tend to be more commonly seen with thyroid nodules. Coming to the next modality, which is 4D CT. So 4D stands for 4-dimension. So the 4 dimensions, the first 3 dimensions in 4D CT are the 3 planes of multiplanar imaging that we have, which is axial, coronal, and sagittal. And the 4th dimension refers to the availability of the change in contrast kinetics over a period of time. So we acquire the 4D CT in 3 phases. The first phase is a non-contrast scan, which is acquired from the hyoid bone to the clavicle. The second phase, which is an arterial phase, is acquired at 25 seconds after the start of contrast injection, and we acquire this from the angle of mandible to the carina, so as to detect ectopic adenomas as well. And the third phase, or the delayed phase, is also acquired at from the angle of mandible to the carina, acquired at 80 seconds. So coming to the findings on 4D CT imaging. So on the non-contrast scan, we can see this parathyroid adenoma, which is hypodense as compared to the adjacent thyroid gland, which is hyperdense due to the iodine content. On the arterial phase, it shows intense hyperenhancement, and a venous phase shows washout. The coronal reconstructed images better depict the parathyroid adenoma as the hyperenhancing lesion, and the ultrasound correlate of the polar vessel sign can also be seen. Coming to CEUS, which is a novel modality which is being done in our department. So we make use of SonoView, and we use a volume of usually 2 to 3 ml of reconstituted contrast. This is first we do an IV injection of the contrast, which is followed by saline flush. Continuous acquisition and scanning is done for a period of 2 minutes, and the lesion shows early peripheral hyperenhancement followed by a central washout in the delayed phase. I'll show a short video to demonstrate this. So this is the carotid vessel, and as we push in the contrast, the carotid shows enhancement, and this is the enhancing lesion, the parathyroid adenoma, which is also showing enhancement as right after the carotid vessel. So I'd now like to call upon Dr. Aditi to discuss the functional imaging part.
Good evening, everybody. And thank you, Dr. Shreya, for such a lucid presentation regarding the anatomical localization. So let me lead you to the functional parathyroid imaging, which we do in the Department of Nuclear Medicine. So the currently available methods for functional imaging include the planar and the SPECT-CT methods, as well as the PET-CT. So historically, what we used to do was a thallium pertechnetate subtraction imaging, where the thyroid gland was subtracted from the parathyroid and the thyroid combined. Now we have a very nice, a unique tracer, which is called the technetium system, which has a differential washout, which has a time, we do a dual time point or a multiple time point imaging, where initially what you see is thyroid and parathyroid. The thyroid will show an early washout, and the parathyroid will retain the system maybe. Coming to a little bit detail about the system maybe scan, the principle states that parathyroid gland has large number of oxyphil cells. These oxyphil cells have many mitochondria, which have avid maybe uptake and have a slow release in contrast to the thyroid gland. We do not need any special preparation or any fasting which is required for the patient. The radio tracer is injected. The patient is asked to lie supine under a gamma camera, and the neck and mediastinum are imaged. We take the first planar imaging at 15 minutes, second at 50 minutes. An early SPECT-CT is warranted at this time in case there is a difficult localization of the parathyroid gland, and a 3D reconstructed image along with a correlative CT is acquired from the base of the skull to the superior mediastinum. Here we see the planar images in the first frame, which are taken at the 15, 50 and 2 hours time. At the 15 minutes, you see a thyroid and parathyroid both showing a system maybe uptake, and at 2 hours, There is a washout from the thyroid gland, and the parathyroid is clearly visualized. The corroborative axial sections of the SPECT CT image show the same very nicely. So when can this maybe fail? When we have a low gland volume or mass, when we have multiple glands, when the patient is syndromic, when there is secondary or tertiary hyperparathyroidism, or the gland expresses a P glycoprotein expression. And here comes the role of PET. We have instituted in our own department fluorocholine PET CT in the year 2015. There is improved lesion detection rate with fluorocholine, high spatial resolution, high lesion to thyroid ratio, its accuracy in multiglandular disease, and visualization of small adenomas are the forte. The principle is upregulation of phospholipid calcium dependent choline kinase. There is no special preparation. Injection of fluorocholine is done in the morning. After 60 minutes, an image is acquired. And here is a typical fluorocholine scan where the right-sided parathyroid adenoma is distinctly visualized. And we can also see in a fused PET CT image, the colored image which shows the parathyroid adenoma. This is a comparative table of the radiation doses where we can see that a planar technetium system EB scan gives an effective dose of approximately 6 to 8 millisieverts. Add on a SPECT CT, it becomes 8 to 12. A fluorocholine gives you a radiation of as low as 3 to 7 millisieverts, a 4D CT between the range of 10 to 15 millisieverts. The overall sensitivity of choline has reached to up to 95%, and we have data from our own department which states the same. And overall sensitivity of maybe according to literature is around 85%. So this is a representative of a giant parathyroid adenoma. We all can see in the planar imaging that the right side of the neck shows an elongated lesion with increased radiotracer accumulation. And when we see the coronal and the axial images, we see a large hypodense lesion which is actually replacing the right thyroid lobe, and we have radiotracer accumulating in it. Another patient with a left inferior parathyroid adenoma, and the SPECT CT images corroborate the same. Thank you, and I would like to call upon Dr. Stuti, who will address the anesthetic concerns of the surgery of a giant parathyroid. Thank you.
Thank you, Dr. Aditi, for the extensive presentation. I'll be presenting anesthesia concerns of hyperparathyroidism. Starting from head to toe, it can cause mental status changes, so it's an individual risk factor for postoperative cognitive dysfunction, that is POCD. Hypercalcemia can precipitate hypertensive crisis, can cause shortening of QT interval and prolongation of PR interval. It can cause trivial fractures, so one should be very careful during positioning intraoperatively. It can precipitate peptic ulcer disease, hence risk for aspiration pneumonia. It can precipitate renal failure as well. All the investigation is already been done by the primary surgical team. We look for complete blood count, kidney function test, including serum electrolytes, electrocardiogram, chest X-ray, and CT scans for AP and lateral airway views. We advise for fasting 8 hours for solids, 2 hours for clear liquids, and IV fluids during NPO period. Morning ABG, including serum electrolytes, especially ionized calcium. Anticipated airway difficulty is there. If it is there, then airway preparation, including nasal xylometazoline drops, glycopyrrolate 0.2 milligram IM to be given 30 minutes prior to surgery, and lignocaine nebulization. Continue treatment for hypercalcemic crisis, tab ranitidine 150 milligram and tab alprazolam 0.5 milligram to be given per oral. What are the immediate concerns of this surgery? It can cause nephrocalcinosis, hence obstructive uropathy, hence deranged care. Calcium levels to be optimized before the surgery. It should be less than 4 millimole per liter and less than 3 millimole per liter if ECG changes are there or renal manifestations are there. It can be associated with Mills syndrome. So one should be mindful that clinical associations have a separate or different clinical anesthesia implications. It can cause ECG changes and serious impairment. As such, in parathyroid surgeries, there are no airway concerns, but if compression symptoms are there, difficult airway can be anticipated. Thyroid position to be maintained intraoperatively. For securing airway, a weak fiber optic and video laryngoscope should be kept. For intraoperative and postoperative analgesia, superficial and intermediate cervical plexus block can be given. Standard ASA monitors to be attached, ventilation and neuromuscular monitoring to be done. Special context to TOF monitoring because calcium interferes with neuromuscular blocking agents. So training 4-count monitors should be attached intraoperatively. For thyroid position, Dunhill pillow or sandbag, neck pillow or head ring are required. Avoid hyperextension of neck to prevent atlantoaxial dislocation or subluxation. Long IV lines to be kept as arms are by the side. Head should be supported and the neutral position. 15-degree head up position to be maintained to prevent venous congestion, but it poses the risk of air embolism. Anesthesia can be induced by general anesthesia, local anesthesia, or local anesthesia with regional anesthesia. But general anesthesia is preferred because airway is not accessible intraoperatively. As such, there is no special considerations for drug during induction or maintenance, but if acute renal failure is there, avoid NSAIDs and sevoflurane. Endotracheal tube and orogastric tube to be secured. Maintenance of hydration and urine output and temperature should be there. Minimum blood loss is expected. If methylene blue to be used, dose should be kept less than 5 mg per kg. After adequate reversal, if recurrent laryngeal nerve or airway injury is anticipated, video laryngoscope during extubation should be used for visualization of vocal cords. Electrolytes should be checked in early postoperative period at 6 hours and at 24 hours for the early diagnosis of Hungry-Boy syndrome and acute hypocalcemia. Postoperatively, analgesia can be administered with IV boluses of fentanyl or patient-controlled analgesia with fentanyl and IV paracetamol. Thank you. I would like to invite Dr. Suneha for the next presentation.
In 1986, John Dockman emphasized the importance of an experienced parathyroid surgeon in the management of a parathyroid disorder. So in the next few slides, I'll be talking about the role of surgeon in the same. So parathyroid disorders can be managed. Traditionally, it was managed through a bilateral neck exploration, which has now become a little more obsolete with limited indication. Focused at what we usually practiced, and minimally invasive parathyroidectomy is newer modalities which are coming up. So like with any surgery, anatomy is an important part of while performing any surgery. So this shows the anatomy of neck. So we can, while approaching parathyroid, which are usually located in the posterolateral surface of the thyroid, we can approach it through two approaches. The first one is the lateral approach, where we go between the ipsilateral sternocleidomastoid and the strap muscles, or the midline approach, where we go in between the two strap muscles, and ultimately we go towards the posterolateral side of the thyroid. The steps of thyroidectomy involves 5 important steps: positioning, incision, dissection and excision, post-excision, and closure. So before I demonstrate the 5 steps in the video, this is the preoperative localization of the patient. So we can see there are bilateral uptake, and this is the case of bilateral giant parathyroid adenomas. So starting the video, so we will start with positioning of the patient. So patient is positioned in the reverse Trendelenburg position with bilateral arms tucked and 20 to 30 degree angles with the horizontal. And the head is placed in the thyroid position, as was already mentioned by Dr. Stuti during the anesthesia consults. This pushes the trachea upwards, which helps us in easy incision. So because this was a bilateral, the incision given is longer. Superior and inferior flaps are being raised in the subplatysmal plane. And the level of dissection depends on the location of the parathyroid adenoma. Following this, the ipsilateral sternocleidomastoid will be retracted laterally. It's being separated from the strap muscle. Juice retractor has been applied bilaterally, which will help us give a better vision. So this is the sternocleidomastoid retracted laterally with the help of a backpaw. Now the midline raphe is being opened between the bilateral strap muscles. This pink circle shows the supromedial retraction of the thyroid. This is the area where the parathyroid should be located, and this is the sternocleidomastoid retracted laterally. So dissection is being done in this area, and this is the parathyroid localized. This arrow shows the pedicle of the inferior parathyroid, which will be clamped between two silk sutures before dividing. So this pedicle has been secured, and it is being ligated between two silk sutures. Now we get a closer view So now we have to maintain two important points: maintain a bloodless field and maintain an extracapsular dissection of the parathyroid and avoid handling of the parathyroid tissue. Hence, we can see that the retraction is being done with the help of the suture which has been applied at the lower probe. The dissection is continued superiorly towards the superior pedicle, and because this is a large parathyroid, it may have additional feeding vessels which we are trying to locate. So the superior pedicle has been identified and it is clamped and is now being divided with the help of a sharp dissection. This is the head end of the patient. This is the vision. So this is the other side parathyroid also being removed. Similar steps are followed. Dissection is done. This is the parathyroid localized. This is the inferior pedicle of the parathyroid. This is the parathyroid being pushed superiorly.
It is not like the surgery.
So this is how it appears at the end of the surgery. So before we proceed to the closure, there is one more important thing that we do, that is we cut open the specimen on table to differentiate it from fat and lymph node, and we can see a nice fleshy appearance and hypervascular area which tells that this is a parathyroid and this is the other parathyroid of the same patient. So right and the left parathyroid, we can see the fleshy appearance. The fifth step comes the closure. We have done a subcuticular closure and the incision almost disappears at the end of 3 minutes. So this is the weight of both the parathyroids, 4 gram, and this has a lesser weight because it was cystic lesion and some of the fluid came out during the incision of the parathyroid. One other, like we follow the Miami criteria for IOPTH monitoring, where pre-incision sample and post-excision at 10 minutes, patient venous sample is sent to the endo lab for parathyroid, which helps us identify the adequacy of our parathyroid surgery. Next, I would like to call upon Dr. Vidya from Department of Pathology, who will tell us about the histopathological features of the excised parathyroid gland.
Thank you, Dr. Suneha. Good afternoon. I will be discussing the histopathology of parathyroid adenomas. This image shows the normal histology of parathyroid. This is composed predominantly of chief cells and few oxyphil cells and variable amount of adipose tissue. In the next few slides, we will see gross and microscopic features of a right inferior parathyroid adenoma. This specimen measured 3.8 centimeter and weighed 5.65 grams. This is the gross image, which shows a well circumscribed firm mass with a yellowish appearance on the cut surface. On microscopy, you can see that the parathyroid gland is enlarged and hypercellular. It is devoid of adipocytes. Normal thin rim of parathyroid can be seen at the periphery. At the high power, we can see the tumor is composed predominantly of chief cells, which are arranged in nests. There is no significant mitosis, necrosis. This is another high power image of the same tumor. Here we can see some oxyphil cells, and this area shows the compressed normal parathyroid tissue. These features are consistent with the parathyroid adenoma. These images show a parathyroid carcinoma. In comparison to an adenoma, the cells of a parathyroid carcinoma show nuclear atypia. There is a coarser chromatin, prominent nucleoli. There is an occasional mitosis seen, and there is presence of lymphovascular invasion. These are the features that help us to distinguish from an adenoma from a carcinoma. Thank you. Now, I would like to invite Dr. Gopal to share the experience.
Thank you, Dr. Deve, for making us expert in histopathology. Now I'll discuss our experience with these giant parathyroid adenomas along with a short review of literature, as Dr. Kiran has covered most of the aspects. So giant parathyroid adenoma is more than 3.5 grams, as we have seen, and it's because of it's more than 95 percentile. So we have 28 years and more experience with the parathyroid surgeries, and we have performed about 528. In fact, this morning we performed the 529th surgery on parathyroids. In these, the surgery for giant parathyroid adenomas has been done in 73 cases, which amounts to about 13.8, that is 14%
which is slightly more than that reported in the Indian literature, which is 10 to 11%. So in the clinical parameters, the mean age of our patient is slightly younger, that is 10 years younger from the reported in the literature, 42 years. Predominant patients are females, which is 65, similar to the reported in the literature. All of our patients are symptomatic, 73. 90% in literature it is reported that 90% are symptomatic. The most common symptom is the renal involvement, 41%, followed by bone pain in 36%, followed by GI symptoms. The hypercalcemic crisis was seen in about 39% of the cases, and brown tumors were seen only in 15% of the cases. In contrast to the palpable lesions, which was reported about 58% in the literature, our study reports only 17% of palpable lesions. Coming on to the biochemical profile of these patients, the mean calcium value of our patients was 12.65, which is increased as the upper limit of normal in our lab is 10.2 milligram per deciliter. The range, however, ranged from 8.9 to a whopping of 18.52 milligram per deciliter. The serum phosphate mean value was 2.4, which is slightly less than the lower limit of normal. Vitamin D in our population was varied range, so we calculated a median, which was 21.63, and the mean was 24.57. The serum PTH mean value was 1136 picogram per ml, with a range of 157 to 3500 picogram per ml. The post-op PTH in our patients dropped to a mean value of 66, and post-op calcium dropped to 10.67. In intraoperative details, the number of 64 patients had single gland disease, 9 patients had multiple gland disease. So total number of excised glands were 84 in our population. In localization, entopic localization was seen in 66 patients, and ectopic was only in 10% of the patients. The mean weight of the gland excised in our population was 9.6 grams, and the median weight was 7.8 grams. This is higher than that reported in the Indian literature, which is 5.6 grams. The range in our population ranged from 3.5 to 31 grams. The largest gland we have excised is 31 grams. The largest reported in the Indian literature is 102 grams, and in worldwide is 145 grams. In pathology, 82 of these glands were adenomas and 2 were carcinomas. So with that as a background, I call upon Dr. Piyush to discuss the outcomes and the conclusion.
Thank you, Dr. Gopal. It is said that a proper follow-up is the worst enemy of good surgical outcome. So let us see how we have had over these years as a team. So if we look at the trend, for the sake of convenience, we have divided into 6 groups of 5 years each. So in the first 15 years, we could operate 17 cases of giant parathyroid adenoma. In the next decade, we operated around 53 cases of parathyroid adenoma. And in the last 2 years, we operated 3 cases of parathyroid adenoma. So this study, we had 40% patients who had hypercalcemic crisis. Unfortunately, we had 0 mortality in this subset of patients with parathyroid adenoma, that is giant parathyroid adenoma. And this can be attributed to the excellent preoperative optimization by our endocrinology colleagues and perfect localization by nuclear medicine and radiology colleague. Of course, time is of essence in these patients. If we get an optimized patient early, favorable outcome can be expected. So as far as the technique is concerned, prior to 2007, most of the cases were done with neck exploration. So neck exploration constituted 24, we operated 24 patients with neck exploration, whereas 49 patients, we could do focused parathyroidectomy owing to good localization techniques. Now parathyroid miss, which is not an uncommon entity with the smaller glands here, owing to the bigger size, it was easy to localize, but remember the 7 cases wherein the gland was in ectopic location, that too was very well localized. Presentation, most of the patients were symptomatic, so we went ahead for localization before surgery. And good anatomical imaging and functional imaging helped us in that. And a meticulous dissection for a proper parathyroid removal, the disease parathyroid removal was done. So fortunately, we had no case of parathyroid miss in this study. Coming to the post-operative complications, post-op hypocalcemia is common after giant parathyroid adenoma removal. So in this study, we had 66 patients who had hypocalcemia, which were treated with calcium supplementation. 2 patients had persistent hypercalcemia because the larger gland, the giant gland, took up the uptake was preferential in the larger gland. The smaller gland was missed. which was diagnosed later. And 3 cases had recurrent hypercalcemia. All these 3 were associated with MEN syndrome. In 3 patients, we had hungry bone syndrome. To conclude, giant parathyroidinoma is a rare subset of parathyroid adenoma. It is not the size, it is the sheer burden of the disease that the patient is carrying. Of course, it's a benign condition, but one should think of malignancy by dealing with giant glands. Most of the patients are symptomatic in contrast to the Western literature, and at times we should always think of severe hypercalcemia because it carries a high mortality rate. And above all, organized team approach is the key when we deal with these big bone breakers. Thank you. Now I'd like to request Professor C.S. Baba. Two, sir. 2 patients. 2.
I would really like to not be able to name them this site calls. Sharma is one of the oldest, he's not that old, the oldest member for a very long time. From the pathology of you will try to go in and laugh. You cannot ask me question from whether you are removed. Sometimes it may be possible to differentiate
not. And one now we still university. When the parathyroid adenoma, the normal parathyroid is not defined. Whenever you are removing the parathyroid in the iron, and you are repeating it to the iron, then you will find the most important. If you got like this, you got like this, you not find. That is very important. And there was a time when I used to, but now I'm wrong. But the concept, I think after 2 years, you have another. Yeah, the concept is the same. Now, what you should tell is how this pattern, this gangland and gland may not be sometimes may be asymptomatic. You should tell the primary hyperthyroidism. Anything which is occurring in primary is all adenoma, not hyperplasia. Only the tertiary get the hyperplasia. Now, the only thing is what we can predict is the some fat in the adenoma. You can take multiple involvements likely. But all enlargement of parathyroid in primary hyperthyroidism can that is not type. Another case when the one parathyroid or adenoma, when the course was removed, and you talk to me, I said no, from very beginning it was or they was on that. I think anything which is if it is a primary hyperthyroid, multiple, that's syndrome. Second, that helps in solving I think it's an excellent presentation and I'm so happy. I've lots of experience. I think that's so both of us so my question is two. One, you said these are basically the bone post-operative aspects related to pre-operative aspects. Right. So what does it mean pre-operative? So my second question is why this in the gets deviation,
The range was quite big. Actually, it's there in almost all studies. You can have it.
Could we have some literature? That's my third question is, it would be very nice to some word literature with such a large series. That's where we know, what are the levels of those series, so this is my comment.
Actually, can you go back to the slide here? We got two series. Actually, most of the cases are case reports. But there is one meta-analysis of 26 cases and 30 odd cases, and we have taken the mean values of the meta-analysis in the right hand side. I said about the alkaline phosphatase, it's elevated PPH, elevated alkaline phosphatase. These are predictors of post-operative.
That's what I want to. What does it mean actually?
And that I'll show you. So these
That's
are
what we teach in the round. Then we look at the confidence level. All figure the calcium.
yes.
So we will select it.
Okay, so it was in the range of around 500 to 700.
The last comment can they be asymptomatic?
Yes. Yes. The meta-analysis I was talking about, maximum patients were rated asymptomatic. Maximum, irrespective of the high calcium.
Anyway, congratulations again.
Okay, the first thing is for the yes,
It's not very strong.
It just gives an idea of how diverse bone breakers to now judging the surface of the severe bone disease. So I just want to know whether an anthric first has never been reflect the severity of bone disease. It's such a case scenario for giant fiber.
And there is a weight of the gland position. It is there, but it is
It's a huge thing in the giant fiber.
So thank you for patient hearing. Thank you. Thank you much.